Right, so now we're going to move on to two stents.
I haven't finished on the literature yet.
Well, we're going to come back, and I was going to ask Miles as a lead into the use of two stents on EBC2. As second author, Dave being first author. So with the concept that if you have a big side branch, some of the criticisms of some of the trials was that maybe you had a small side branch and there wasn't enough kiss. And if you have a big side branch, the question is, should we really be using two stents? And I'd like you to put an argument together for two stent in EBC2 versus provisional, if possible.
That's very difficult.
That's a curveball, isn't
it? It is a curveball on the spot. Just to go through, so EBC2, you're quite right, because most people will always say, the provisional strategy is fine for simple lesions, but one of the criticisms of the earlier trials is that sometimes patients didn't have true bifurcation, so diseases in both arms, and they didn't have some of the side branches were not that large. So to specifically address the question, EBC2 looked at large side branches with disease extending from the ostium at least 5 millimeters. And actually, the results showed that still provisional strategy was as good as a complex planned culotte, with a benefit in terms of periprocedural infarct and contrast and procedural time.
So could you say that you shouldn't feel bad if you decide to do a culotte in a large vessel system, if you were concerned that you didn't want to do a reverse culotte, or you thought you may end up having to intervene on the side branch? I think could that be a positive thing to say? I know it's a curveball, and you
could say from the data that a planned culotte is as good as a provisional if you ignore periprocedural infarcts, and which may or may not be of relevance, and also you ignore the procedural time. But generally, it's more difficult to say that.
But one of the nice things about the fact that the literature is all consistent is that this technique can be all provisional. It doesn't matter if you start off provisional. You don't have to say at the outset, I'm going to make this a culotte, come what may. You start off provisional, and if at the end the side branch is big and diseased and dissected by what you've done and you're kissing, fine. Turn it into a mini culotte. No
but
problem
if you were
with
to,
that. And in
if
fact,
you were to do
in
a culotte,
in EBC2, 1 out of 6 cases did end up with a two-stent strategy because they were complicated lesions, but the other 5 out of 6 didn't need it.
I mean, one of the things that operators occasionally do have and they're nervous about is that if you're going with a provisional, you don't necessarily prepare the side branch, as we discussed, as well. And there are some times where you do get surprised with calcification, eccentric plaque in a side branch, and then you would have thought, if I was going up front with two stents, I might, rotablate or even take a cutting balloon in the side branch, and that may be one difference, and that was.
That's within the consensus statement.
Yeah.
If you've got a big branch, which is really difficult to wire, or the flow is lost early in the procedure, and you feel that actually it is not the safest technique to put a stent across it because you might not get back across, then you put your first stent into that diagonal. And, no one's saying that there is a one-size-fits-all for every single case here. And if you've got a diagonal which in the process of wiring, the flow's gone down, and your ST change, then you're going to have to sort that out. I certainly feel in my practice there are cases where I set out to do a two-stent strategy because I think that's going to be the best thing to do. I don't feel bad about that because it's the right thing to do. And that might involve rotablation of both branches, perhaps in a heavily calcified left main, and it's going to be a culotte right from the outset. And I don't think that's wrong. That said, trying to do a complex stent procedure in a lesion LED diagonal where actually it's just an ostial nip, which is on the pre-procedure angiogram, but you're quite fancy doing a culotte, that probably is not the right thing for your patient.
So we're going to move on to specific lesion subsets, and Adrian, I'd like you to start. And really, you mentioned the left main, and really the left main is the one area that operators are nervous about single stent strategy. I'm going to come back to the literature for Dave, but what do you do in particular when you're faced with left main, and what tips have you got to help us when we're faced with this, maybe in the middle of the night acutely, or it may be patients that have been sent to a centre for surgery and then turned down, they're coming back to you and you're thinking about your strategy?
Well, acutely, you just do whatever you've got to do. And I think acutely, particularly in a STEMI setting, the left main is just another coronary artery, and you just got to look after it exactly as you normally would. If the circumflex is big, you put 2 wires down and you try and make sure at the end of the case you've got flow in both wires, down both vessels. I would try and use 1 stent, particularly in that scenario. I think where the left main becomes particularly relevant is in stable disease or in an ACS setting. Patients are often elderly, the vessel is big, the vessel is usually calcified, and you can expect calcification in my view. And I think if you go into it hoping it isn't as calcified as it looks, you are wrong. It will be calcified. And I think you could almost say that in patients 75 plus, if you're not prepared to do some either rotablation or serious plaque modification, you should do some IVUS just to be sure. I mean, that'd be my rule of thumb, really. I either image or I plaque modify, usually with a rotablation. And the reason, in part, is you've got a limited amount of space in the left main. And unless you get rid of some of that plaque, you will end up pushing plaque one way or the other. And as a consequence, you end up with a suboptimal result. Now, sometimes in a small circumflex, it really doesn't matter. But you've got a dominant circ, you're going to really need a good result in both of those branches. So for me, careful lesion preparation is key. Appropriate dilatation with a balloon, be sure that I can expand before I put stents in. I'm looking for a prioritization of the vessels, which usually is LAD is the most important, circumflex is the next most important, and intermediate is not going to be important, but sometimes that varies depending on the anatomy. And I'm going to try and use as few stents as possible. And if I can get away with 1, I'll get away with 1.
Would you say, on the whole, you tend to use 2 stents in left main bifurcation disease, or?
I wouldn't necessarily say that, to be honest. I think if it's a dominant circ, then I think I have a lower threshold. I accept that. But there are lots of left mains, but actually the circ isn't massive. And if I'm happy with the result I get with 1 stent, then I'll take 1 stent.
Dave, you're...
So I will try really hard to use just 1 stent in the left main. I mean, I think there are 2 main reasons for that. One, all the evidence we have at the moment suggests that outcomes with a single stent are better. Now, it's all flawed. None of it is randomised. So you have to take it with a pinch of salt. But one of the big things with the left main, which is very different to the LAD diagonal, is the much bigger angle involved. And if you take a stent and arch it round all the way into the circumflex as well as one in the LAD, your chances of having either stent fracture there with repeated bending or low shear stress and near intima formation is really very high. And all the evidence, in fact, both from single and double stenting, is that at the ostium of the circumflex is where you get the re-narrowing appearing again. So I will try really hard to use 1 stent if I possibly can and avoid shoehorning a metal tube into an unfavourable morphology.
Do you open the struts into the side branch, and then there's obviously criticism about balloon injuring vessel,
people,
even if it's clear of disease. Is that an unnecessary fear?
It's not an unnecessary fear, but people have been going on and on about that for an awful long time, in the face of the evidence, which is that for whatever reason, and I can't tell you why, it doesn't seem to matter that much. You know, the clinical comeback rate from Nordic, BBC, or all of the studies where doing a balloon inflation into basically an uncovered side branch was part of the protocol, all of them nonetheless have had clinical event rates which are in single digits. So it clearly isn't that bad a thing to do.
So what you highlighted there, ostium circ, Dave, is absolutely the Achilles heel of the left main procedure.
Yeah.
Right? We know that it's often calcified. We know from the Korean data that if there's a high plaque burden at that point, you've got a problem. We know for sure that if you use 2 stents and you don't get a decent MLA at the end of the procedure at the ostium of the circ, that it not only relates to, it relates essentially in almost a linear fashion to bad outcome. Patients represent with a problem, either stent thrombosis or restenosis causing angina. And so I think that's where lesion preparation comes in, it's where technique comes in, and it's then where imaging starts to really make a difference. And although it's perhaps simplistic, this 5, 6, 7 rule is quite helpful, I think, with regard to just having numbers in your head as to what you need to achieve with a 2-stent strategy in the left main, just to be sure, particularly, that the ostium of the circ is covered and you've got a good result with balloons. And actually, the problem is it's often very difficult, even when you have prepared, you think the lesion pretty well, to get a really good result of the ostium of the circ. And as we move into a population where we're offering stenting as an alternative to surgery, scrupulous technique, optimal procedural results are essential. If you could have had a bypass instead.
So you know, I'm a big fan of intracoronary imaging, and Miles, you know, we've heard we should be doing, you know, some form of imaging. IVUS was mentioned, OCT we saw yesterday. You know, what do you think? OCT, IVUS, both? Which machine? What are we looking for? Help us out here.
So, well, personally, I prefer IVUS, just because I feel I get more information for IVUS with regards to the left main, particularly about stent apposition for me. And also, it's what I am more comfortable with.
So, not non-left main. You'd still go with IVUS, or you think there's
I would be
roles
happy
for-
I'd be happy to use either.
Okay.
There. Certainly, yesterday we saw cases where, you know, there's problems with renal function, or there's problems with the guide sitting nicely at the ostium. So those ones you'd be more cautious with OCT. Whereas IVUS allows you sometimes, you know, you can actually stop. You can do a manual pullback and find out exactly where you think the problem is and what needs to be done. So my personal preference would be IVUS. However, both are possible with caveats.
And we're seeing a lot of use of the sort of 20 megahertz catheters, when previously we used to see quite a lot of the 40, 45 megahertz. Do you know, we saw some chroma flow today. Which catheters do you tend to use, or is it?
Well, we tend to, for me, I'm not so, I tend to use specifically, the 5 French, because I find that is the most easy to pass through stents, and that's the one I would tend to go with. But also that requires you just to clear the vessel with saline properly, and to have the system flushed very well.
And in the left main, would you routinely use IVUS?
I think that I have to sometimes. I would like to say that in the majority of cases I would. Majority.
David?
Yeah, I don't actually, and I know
Even in left main?
I know I'll get criticised for that on this show, but in fact in EBC main, which we'll probably discuss a little bit, I wanted to have a randomisation to IVUS or not IVUS, because the evidence that there is okay broadly in that direction, no question, but everyone trots out that graph from Park, which separates at about 4.5 years when there are only 6 people left in each arm. So, yeah, I think we need a bit better quality data than that, and it would have been really nice to do it, but unfortunately for a variety of reasons we
Is
can't.
that Spanish data as well, isn't there?
Do we have...
Yes, there is now.
Adrian,
yes.
do we have a roundtable conflict at all? Do you
Can I
would you say
can I
use IVUS?
just the reason I say that is, if you do IVUS in your first 50, let's say, or 100 left main, then you have mostly learned the lessons. You pretty much know what the size of the artery is, and you know you're going to have to take the balloon up to 26 usually, you know, to really hammer away at the ostium of either the LAD or the circ or both. So, and you can't really do much more than that. So I'm not 100% convinced. I'm completely happy to be proved wrong, but I'm not 100% convinced that
Adrian,
it's absolutely necessary.
Yeah,
As somebody that we are learning from, we've always been a proponent of IVUS in the left main.
I would say, if I'm putting 2 stents in, particularly if it's an elective procedure, why not do an IVUS? You will learn something. Now, you might learn something that's useful to you, and you might learn something that's useful to the patient. You might do both. But actually, it doesn't take that long. And so for a 2-stent procedure, I think IVUS or OCT. And I think, excuse me, I think the difference actually is increasingly generational. The young guys like the OCT pictures. Old people like me like the IVUS pictures.
Old people like you and Miles.
Well,
I like the IVUS as well. I think you actually get to see the vessel size.
but Nils Nils has done really great work with that October study, looking at a prospective way of using OCT to answer the questions that you need to perform that bifurcation left main procedure well. And I think that's a big step forward, actually. So for me, I think IVUS is helpful. I think the other thing we've now got with better catheters is we're not risking the result, shoving bulky catheters and crushing stents, which, perhaps we were doing 3 or 4 years ago.
Yeah.
So I would, as we move into, as I said, this new era, potentially with left main, where we're doing younger patients, we're doing perhaps more complex, older patients, intravascular ultrasound will teach you stuff. And so where I kind of usually often, so for me, I'll often do IVUS of the least diseased vessel pre, because I know where the stent's going to go. And it just gives me a bit of an idea about how likely it is that I'm going to need to use 2 stents from the beginning. And if you've got a really diseased, horrible-looking circ, for that example, which angiographically didn't look that bad, then I might just use 2 stents. I mean, that might be, a big circ, I might just say, look, I'm going to just go for a 2-stent strategy.
For me, I think for left main, one of the worrying things, the things I want to get correct, is for stent choice. The difference between the LAD and coming back into the left main stent. And I think IVUS or OCT gives you the confidence to know what the size differential is going to be and what stent platform then to choose, so that you can make sure that you're going to expand up into the left main stent.
As a chairman and as somebody that's faced with these, one of the things that we like to see, and I support David on this, is evidence-based practice. And I am an IVUS fan, and I can understand that there's concerns of using kit in an area may be uncomfortable anyway, and adding time to a procedure. And so would you agree that it's a shame that there wasn't an IVUS arm in the EBC main, which we'll talk about?
It probably wouldn't have shown much. That's one of the things that we know, is if you're good enough to use IVUS, if you need to, then you're probably using the technique that IVUS has taught you most of the time.
But
I think that's the argument.
Yeah.
But wouldn't purists say, from an academic, you're both professors, so that you would ideally have a randomised trial to show that?
Yeah. But the randomised trial would have to be massive to have a clinical impact. And therefore you take a series of surrogate markers, which, to be honest, nobody's really going to take as class 1 evidence that IVUS is necessary for every left main. I don't think we're ever going to get a trial that's going to say that. And ultimately, there's enough kind of on the table questions to answer, I think, without having to put that imaging thing in. I think if you're comfortable with imaging, you should image. And actually, if you're not comfortable with imaging, you shouldn't be doing left main.
Also, I suppose with XL and Noble just out, we're still relatively early days of left main. So it may be, as Dave says, that as more and more of the procedures are done, then you realise you're reassured without.
So 75% IVUS in XL. So high penetration of IVUS.
Not in Noble.
I didn't say Noble.
And what was it in syntax?
Oh, a lot less. And because in syntax, syntax was a great study, but it was wham bam crash angioplasty.
Yeah.
How many stents can you put in one setting? And it actually reflects. I'm almost slightly embarrassed when I think back to the technique that I was using when I was recruiting patients in syntax. Angiographic-based decisions. We set out to do as many stents as we felt were necessary at a time where we felt drug-eluting stents were the best things since sliced bread. And what we now know with pressure wire is you can get a better result for the patient in a number of cases without putting a stent in at all. And that's why we've moved on from syntax, and why, in my mind, syntax 2, FAME 3, these evolution of technique trials are probably more important than different stent platforms. It's a way in which we use our stents, which will actually improve outcomes now, because the marginal gain from different polymer, whether the polymer is just luminal, how the stent is cut. I don't think it's been that much difference. We've got good stents. We haven't got perfect stents. Now, I would like to see, more evolution in stent platforms, but ultimately what we need to do is we need to use them more accurately and more stringently, really.